Hi everyone, and welcome to today's, the June 2022 Smoking Cessation Professionals webinar. It's a great pleasure today to have Raglan as our presenter, just to kick off things a little bit prematurely just before NAIDOC week, but a very timely presentation indeed. First of all, just like to do the acknowledgement of country. The Australasian Professional Society on Alcohol and Other Drugs respectfully acknowledges the traditional owners of the land on which we and our events are located. We pay our respect to all elders past, present and future, and acknowledge Aboriginal and Torres Strait Islander people who may be joining us today. So just a quick disclaimer, the views expressed within this webinar are the presenter's own and are not necessarily the views and opinions of APSAD. The Society does not accept responsibility for any information, research, recommendation or advice contained herein. So today we have the absolute pleasure of having Dr. Raglan Maddox from ANU that will be presenting on Indigenous excellence in reducing smoking prevalence. So Dr. Raglan Maddox is from the Modewa Clan in Papua New Guinea, and his program of research is focused on Indigenous tobacco. This research has been generating primary data and returning data to Indigenous communities to help better understand and improve Indigenous health and wellbeing. Raglan works with Indigenous communities and service providers to obtain information to better understand, inform and evaluate tobacco and nicotine programs and policies. Can I ask that you please put any questions into the Q&A function, and we'll do our best to get through those questions in a timely manner. So that's it from me, and I'll catch you on the other side at the Q&A. So I'll now pass on to Raglan to start his presentation.
Thanks, Ryan. Hopefully you can see my screen. I'm going to look for you for the thumbs up, Ryan.
Yeah,
perfect. Sorry, a bit too premature. And yeah, it is a timely presentation to look at Indigenous excellence in reducing smoking prevalence and the opportunities that we have. As Ryan mentioned, I'm Raglan Maddox. I come from the Modewa Clan in Papua New Guinea. For those of you who don't know, PNG is Australia's closest geographic neighbour, and the sort of image in the middle there is where I'm from specifically, so Milne Bay, Milne Bay, and there's sort of a photo or a map at the back of this image which highlights, I guess, Papua New Guinea and Australian relations. So Papua New Guinea has only been independent since 1975, and prior to that was governed and I guess a colony of Australia. So there is an interesting relationship there that's ongoing, and now that the borders are opening up, I guess on the right-hand side, I have a bit of a tourist brochure to encourage you all to get up there and enjoy the snorkeling and scuba diving if you ever get a chance. The other piece I like to highlight is the photo at the top right-hand side, and that's a photo of my mother in the sort of blue circle at a boarding school at Quado Boarding School, Quado Island. And the reason I highlight this is to reflect on, I guess, the impact on the ongoing impacts of colonisation. So my mother and I guess part of my family ended up in Australia through the independence movement, and so grew up in Canberra. But on her Australian citizenship and her Australian papers, she actually has 3 different birthdays. And so that has serious implications for accessing healthcare or visas or other challenges. And so those ongoing impacts continue to hinder access to programs and services, including smoking cessation services. So that's a little bit about me, where I come from. The reason I like to talk about that is it sort of shapes and informs my worldview, and I'll speak a little bit about Indigenous worldviews in a minute. But also influences the way that we approach research and everything about that. So in recognising my worldview and who I am, where I come from, I lean quite heavily on a group called Tithu Thame. And Tithu Thame means to share knowledge, and that's the reference group that provides advice to the Aboriginal and Torres Strait Islander Research Centre here at Australian National University. And they provide guidance from preconception of any research or evaluation right through to dissemination. And you can see around the outside of this slide, we also have obviously funding bodies. We have different teams, evaluation or research teams. We have our community partners. state governments or federal governments and others. And they all sort of play a role in this research that we undertake. And I'll sort of share a number of findings from some of the work we've undertaken over the last 4 years or so. Similar to that and building on that, and I appreciate the positive feedback I've had on the artwork. This is a piece of artwork called Unity, and it's done by Jasmine Sarin, who many of you may know, who was involved in the ATRAC tobacco program at AHNMRC in probably around 2010. And she did this piece of artwork for us called Unity, and it's has the colours from across Australia, so you can see the blues and greens of the Torres Strait and the waters of sort of Cairns and the Great Barrier Reef and other places. And then you've got the ochres and the reds and the red dirts of Central Australia to highlight the diversity of Aboriginal and Torres Strait Islander people across the country. And then you've got circles around the outside, or circles everywhere, interrelated circles that are sharing knowledge, information to support people to be smoke-free, to make quit attempts. So you've got NGOs and academics and Aboriginal health services and others coming together for the greater good, for the health and wellbeing of the community. And so I think when I sort of consider this program of work, I think that those sort of principles are fundamental to any of the work that we do, and it's around what are the tangible benefits for Aboriginal and Torres Strait Islander people. And that's one of the great reasons, I guess, that and the opportunity to present and share some of this information with you today. It's also a great reason to celebrate NAIDOC Week and to acknowledge that excellence. I say that and I acknowledge that diversity, and then I cram in 60,000 years of information into one slide. And this is to provide some context for tobacco use across Australia, specifically among Aboriginal and Torres Strait Islander people. And most of the information I'll be sharing today is specific to Aboriginal and Torres Strait Islander people, unless I sort of suggest otherwise. So as we know, Aboriginal and Torres Strait Islander people are the oldest living culture in the world and continue to thrive today. But we also know the implications of colonisation, which included the introduction and embedding of commercial tobacco. Previously, tobacco wasn't necessarily used or embedded in the same way before it was introduced through colonisation. And coloniality meant that prior to engagement with the cash economy, in the 60s, Aboriginal and Torres Strait Islander people were paid in rations of flour, sugar, tea and tobacco in lieu of cash. We also know that is a diverse relationship, and there was some trade, particularly in Northern Australia, with the tobacco plant. We also know that Aboriginal and Torres Strait Islander people have been excluded from the cash economy and the education system, and this has implications for tobacco prevalence and tobacco use. Obviously, those sorts of systemic issues mean that Aboriginal and Torres Strait Islander people are disproportionately exposed to risk factors associated with tobacco use. The other thing that I have on this slide, which is interesting, is that Philip Morris and others have targeted Aboriginal and Torres Strait Islander people. So down the bottom left-hand side, you'll see a letter that went out to Aboriginal medical services, Aboriginal corporations, promoting e-cigarettes and raising awareness of these. So these types of ongoing challenges continue today. I also wanted to flag the work of Professor Tom Calmer in 2005. Professor Calmer did the Social Justice Commissioner report, which raised awareness of the life expectancy gap between Aboriginal and Torres Strait Islander people and non-Indigenous people, and touched on and highlighted the influence of tobacco use in that. And I'll speak a little bit about smoking-related morbidity and mortality today. In acknowledging that diversity, I think it's also important to acknowledge that there was 500 different, 250 different languages and 500 to 700 different dialects across the country. So while I'm sort of speaking relatively broadly about tobacco use across the country, there is a diversity of views and different challenges, infrastructure experiences across the country. And so I want to really avoid any pan-indigenising or anything like that. So it's critically important, the work that we do, and I sort of have this research program has a footprint across the country, that we engage and acknowledge local Aboriginal and Torres Strait Islander peoples and their views and experiences, because their relationship with the tobacco plant and tobacco use is going to be different across this diverse country. We also know that when we look at the literature that there tends to be a focus on ill health and disadvantage, and that continues to perpetuate this deficit discourse. So the work that we do, and you see that sort of from our governance structure with Tithu Thame, from preconception all the way through to disseminating results, we try to centre that information on Indigenous peoples, their worldviews, and acknowledge that there are differences and challenges around that. The other thing that I didn't mention on the previous slide was around the White Australia policy and other challenges that have sort of established and perpetuated this, I guess, genetic difference or the misconception of genetic differences and racially inferior people. So that's one of the challenges that we continue to see, particularly around things like nicotine dependence or addiction, where people might suggest that some of the reasons for high prevalence or higher prevalence among Aboriginal and Torres Strait Islander people is due to genetic predisposition. As we know, race and indigeneity is a social construct, so we really need to challenge some of those incorrect perceptions. We also, as I've sort of gone across the country, need to challenge, I guess, or be open to some differences in thinking and to understanding all the factors that influence tobacco use. So I sort of spoke about colonisation, and you can see at the top there, on the top right is colonisation, I guess those experiences of racism, discrimination, dislocation, the introduction of tobacco. And you can see all the different I guess factors that influence tobacco use and sort of result in having a smoking prevalence of 40% across the country, daily smoking prevalence. The other thing that this sort of image is trying to highlight is the diversity and the dynamic nature of smoking and smoking prevalence. So we know that, and to such an expert group like yourselves, I won't have to go into too much detail, but smoking and non-smoking is not necessarily a linear relationship. It's not always binary in that today you can be a non-smoker and tomorrow you might take up smoking, or you might make a quit attempt. So depending on what other influences are going on in one's life might influence a whole range of things, including tobacco use. And so this is just one way or one tool that we use to try and understand and unpack that. The other reason we use this is sort of as a logic model in trying to understand big data. So when we're looking at different data sets and we're looking at impacts such as the impacts of the Tackling Indigenous Smoking program, we want to understand not just do you smoke, yes, no, but the whole range of things that influence smoking behaviours, including attitudes, including smoke-free homes, including changes in intergenerational changes. So we know, based on the evidence, that multifaceted different aspects of tobacco control programs and policies involving collaborations with different sectors tend to be more successful. We know that they have to be culturally safe. I already spoke a little bit about colonisation and racism. So they have to be accessible. And we know that everyone's different. So there are a range of approaches that support people to be smoke-free. And so we look at all these sort of different indicators, looking at smoking rates, attitudes and exposures to have a better understanding of what's going on across the country. The other principle that I mentioned earlier is that of returning data and knowledge exchange. So no point doing research if we're not going to share it and if people can't act on it. So we look at a whole range of administrative data sets to help piece together a picture of what's happening across the country. This includes ABS data, so the Aboriginal and Torres Strait Islander Health and Social Surveys, national perinatal data, national key performance indicators, so health service data, PBS data and quitline. So there are a number of the data sets that we look at, and I'll provide a bit of a snapshot of some of that information today. So that's sort of the context, and hopefully that's raised a few questions, and I look forward to the discussion. The next part of this is just looking at prevalence. So we know that there actually has been incredible success in tobacco control and reducing tobacco use over the last 15 years. So since 2004-5, we've seen a significant decline in smoking prevalence from about 50% to about 40% among Aboriginal and Torres Strait Islander people. So this is specifically a 9.8% absolute decline in daily smoking. One of the other unique factors about Aboriginal and Torres Strait Islander smoking is that smoking among men and women is fairly similar. So you can see males and females here, both about 50% in 2004-5 down to about 40% in 2018-19. And this is quite different to many other prevalence or tobacco epidemic curves, in that generally men smoke at a higher prevalence among men than women, or much higher, I should say, not a couple of percent. But when we unpack that, and I spoke about the diversity before, there's some different stories going on. You can see among youth and young people, particularly in urban and regional areas, we've seen massive declines in daily smoking, and we've sort of seen that across the life expectancy and urban life expectancy, across the life range among urban and regional areas, and you can see those significant declines. But in remote Australia, the story is slightly different, and I suspect that's reflecting the differences in infrastructure and norms and other challenges, including access to education and the economy, that is different in those parts of Australia. The other thing to highlight is that there are about 150,000 daily smokers living in urban and regional areas, in comparison to about 50,000 in remote areas. So not only is the infrastructure different, are the relationships different, but also the absolute numbers of people who smoke is very different. So some of the work we do is focused, or a large part is focused on the Tackling Indigenous Smoking program, and I'll talk about that in a second. And I acknowledge that it is a public health program and not necessarily a one-on-one cessation support. But there is an opportunity where they are driving interest in cessation and promoting different referral pathways, which is one of the reasons I thought it might be useful to share some of this information with you. The other thing we know is that the Tackling Indigenous Smoking program, as it sits currently, services about 75% of the population. So about 25% of the population, including a large part of Sydney, are not serviced at this stage by the program. And so that is something that they're looking to change in the forward years, so over the next 4 years. So at the moment, you can sort of see that the back map there is the Aboriginal and Torres Strait Islander language map. And then you're seeing the evolution of the program, the Tackling Indigenous Smoking program, to the current coverage today, which is the map at the front. So the sort of off-white colour up the front is areas that are not currently serviced by the program. And what is the program, you might ask? So the program is a public health program that includes a range of supports, and it has evolved a little bit over time. They include sort of smoke-free policies, so developing, implementing, maintaining smoke-free policies, which include workplaces, cars, homes, sports and community events, so Koori Knockout, Murray Knockout, things like that. A range of social media and mass media campaigns, promotional resources. So if ever you've gone into a medical service or school or something like that, you might see promotional posters, pamphlets, and the standard sort of media. Community engagement and other activities, World No Tobacco Day events, cessation supports. And this one I'm just going to touch on for a minute, because in the program's development, it originally included cessation supports. So this has changed a little bit over time. And then more recently, we've seen the rise of anti-e-cigarette and anti-vaping type activities. And I'm also going to reiterate Ryan's thing. If there are any questions, feel free to drop them in the chat. Otherwise, I'm sure Ryan will have some questions for me. So one of the pieces of information or data sets we looked at was the MyQI data set, which is a longitudinal study of Aboriginal and Torres Strait Islander health and wellbeing. And it focuses on strengths. And one of the things that we found in this national study of about just under 10,000 Aboriginal and Torres Strait Islander people were that 76% of current smokers wanted to quit. We also know that about 70% of Aboriginal and Torres Strait Islander people who smoke across the country wish they never took it up. So there's incredible interest in quitting smoking or never taking it up, and there's a real opportunity to try and continue that, to accelerate that change and promoting smoke-free norms. We know that 60% of 60% of participants reported community disapproval of smoking, and similar to other populations, motivations for quitting included health costs and health of the family for current and past smokers. We also looked at differences between areas serviced by the Tackling Indigenous Smoking program and those not serviced, and we found that among participants who lived in an area serviced by the Tackling Indigenous Smoking program, there's a 15% higher prevalence ratio of smoke-free homes compared to areas not serviced by the Tackling Indigenous Smoking program. And we also found among people who smoke that there was an 18% increase. So among people who smoke was a significant difference. And when we're talking about a national program, when we're looking at basically 1 in 5 people having a smoke-free home, among people who smoke, it's an incredible difference. We also found indicators of lower nicotine dependence as well. So smoking more than 21 cigarettes per day, and then also smoking a cigarette within 5 minutes of waking. We also looked at anti-smoking behaviours. We found among current smokers, 45% tried to quit, 48% tried to reduce smoking. We found that among past smokers, 66%, so about 2/3 or 2/3 exactly, quit unaided, and 67% of those past smokers quit more than 5 years ago. So some encouraging but not overly surprising results in that space. And this is just a highlight when we're looking at some of this population data, and it's slightly different to an RCT or a trial or something like that, which might be of particular interest. That sometimes when we're looking at what might appear to be relatively small numbers, the effects at the individual level can actually be massive at a population level. So when we're talking about the fastest growing population, we're talking about a population group that 50% is aged under 25. Those sorts of changes are important and actually incredibly significant. The other bit that we looked at was, and this sort of advice comes from our governments and others, is that we want to look at Aboriginal and Torres Strait Islander specific data. And so previously we hadn't actually seen smoking mortality data specific to the Aboriginal population. There'd been projections and other things which had sort of suggested 1 in 5 Aboriginal and Torres Strait Islander deaths were due to smoking. So what we did was we followed Aboriginal and Torres Strait Islander people for 10 years, and we looked at people who smoke compared to people who didn't smoke. And what we found was that people who smoke were 4 times more likely to have the risk of early death. There's obviously a dose-response relationship, so more cigarettes increase risk of early death. Quitting at any stage lowers the risk of death. But actually what we found, and quite striking, was that 37% of all Aboriginal and Torres Strait Islander deaths were attributable to smoking. And of those aged 45 and above, half of all deaths were due to smoking. So this is a phenomenal opportunity for change. I'll put this up here because it's useful to also acknowledge and to hold governments and others to account, I guess. So the WHO Framework Convention of Tobacco Control, which Australia is a signatory to and has signed up for about 20 years now, also highlights the need to take measures to promote the participation of Indigenous peoples and communities in developing, implementing and evaluating tobacco control programs. And this is sort of highlighted through the Tackling Indigenous Smoking program, but not limited to that type of work, which are predominantly at Aboriginal community controlled health services. And it includes the need to have programs that are socially and culturally appropriate. So we talked about cultural safety and some other things earlier in the piece. So in summary, and I'll try to open it up, I think we've got about half an hour left. But in summary, the deadly news is that we've seen since 2004-05 that there has been a 10% reduction in smoking prevalence from what was relatively stagnant before that. We've seen many, many lives saved and almost 50,000 fewer daily smokers today than there would have been if prevalence rates had stayed the same in 2004-05. And that's pretty much it, Ryan. I haven't seen any questions pop up, but
I think we do. Thanks so much, Ryan. We have one question there. But thanks so much for a great presentation, and keeping well to time is always good, so everyone can have an early lunch break, which is great. But I'd always admire your ability to put 60 years of history into one slide. 60,000, yep, sorry. Quite impressive. And I was wondering what your thoughts were with, 9.8% decline in reduced rates of smoking. And I'm not sure how closely you've looked at the national tobacco strategy in the consultation draft. But given your wealth of expertise and looking at all those different categories of area of work you've got in the TIS program there, I mean, Where do you think we can improve or change the way that we're doing things at the moment? Is there certain areas that you would like from a policy level for us to expend more energy on, or do less of something else, or what have you seen in the community?
Yeah, great question, Ryan. First of all, I was going to say I don't think we need to do less of anything. I think we know sort of that multifaceted approach works, and there's some good questions that have popped up, so I might try and answer some of them along the way. And I do note that 66% of people have quit unaided, which is phenomenal in some ways, but also an opportunity in others. So I think we are seeing people want to quit. We're seeing a discussion around that has changed. When I go back to sort of 2008 to 2010, the discussion around smoking in communities was very different to the discussions that are happening today, where there is a thirst for different supports for people to quit. So I look at someone like Dr. Michelle Kennedy from the University of Newcastle, who's just rolled out a study, cessation supports, and the demand for supports and a whole range of different supports is there, and people are wanting to quit and make that change. Whereas I think previously there wasn't necessarily that awareness or demand to change. And so I think as public health professionals and cessation specialists and others, I think we have this opportunity to I guess cash in to some degree on that opportunity where people are wanting to quit. If there are different ways we can get around communities to support them in whatever way they'd like to quit, then I think there's that opportunity. So I wouldn't suggest that we reduce anything we don't do. I think there are opportunities for more coordinated and strategic supports. I guess one of the reasons I sort of put up that spiral diagram is because we have all these touch points through the health system, through social systems, where people are engaging, but aren't necessarily getting smoking cessation support or aren't necessarily being asked about smoking status. So we know on the NKPI data, National Key Performance Indicators, among areas serviced by Tackling Indigenous Smoking Program, about 80% of clients are being asked around smoking status. And in non-TIS serviced areas, it's about 70%. So pretty good, but it could be 100%. Like there could be some systems change to make sure every time you go in and you go through that intake process, that someone is asked about smoking status. So that's an easy one. And then whatever those referral pathways are, I think you're obviously based in Sydney, but if we look across New South Wales, each referral pathway is quite different across local health districts. The way people access NRT is different. The way people access supports is different. So if we can sort of streamline or coordinate that process so that it's a bit easier, that'd be great. The other piece of information that's useful to know is, and we just went out and we surveyed or spoke to a bunch of, well, basically anyone who's working in Indigenous tobacco control across New South Wales recently. And about only a third of them were directly receiving funding to do smoking cessation work or tobacco control work. So there is an opportunity there, I guess, for coordination, funding and sustained effort to support that, given everything we know about smoking. If that answers your question.
Yeah, no, thanks, Raglan. Yeah. So yeah, we do have a few questions. So the first one here is from Sarah Clifford. Why was there a move away from TIS providing cessation support?
Yeah, it's a good question. So originally the Tackling Indigenous Smoking Program was rolled out, and it was called the Regional Tackling Smoking Healthy Lifestyle Program at the time, as part of the Closing the Gap agreements and the partnerships with federal and state and territories. And so states and territories had the focus on cessation, and the federal government funded the public health initiative, basically. So it started off in population health, and then as governments and other things changed, there was a bit of, I guess, policy drift or creep or something like that. So there was that was sort of where the cessation focus came in. And also, I guess, one of the challenges people face is if someone's in your service and wants support, it's hard to say no. So if you're a Tackling Indigenous Smoking Program officer or policy officer, or a tobacco action worker or something, and you're rolling out a campaign and someone says, can you help me quit? Of course, it's very, very hard to say no, and you're in a medical service. So there are ways that you can do that. So, and then I guess in more recent times, it's come back to that population health approach, but there's, I think there's still some work that can be done across those areas. And you see in some areas, like the ACT government, for example, funds a cessation worker to support the Tackling Indigenous Smoking Program. And you sort of see bits and pieces like that across the country, but there is a lot of variation across states and territories, let alone across the country.
Yeah.
Thanks for the question, Sarah.
Yeah, thanks for that, Raglan. And then we do have a question from Siobhan. Is there any data on vaping?
Yeah, there is. There's good data on, or maybe good's a stretch. There is data on vaping, and youth and young people in particular are taking up e-cigarettes. I know the longitudinal study of Indigenous children also has data on e-cigarettes. So that's one of the first times that we'll have data on both tobacco and e-cigarette use among Indigenous kids. So we're seeing an increase there. I think the last couple of years, so the most recent data, I think, shows about 1 in 10 kids have used e-cigarettes. But I think realistically, since COVID has been impacted, based on the, I guess, anecdotal evidence from teams and calls from primary school principals and high school principals, that since COVID's hit, there's been a real increase in e-cigarette use, particularly among youth and young people, but not just youth and young people, it is across the board.
Thanks, Raglan. We look forward to when you do have the data, to feel free to come back maybe later in the year once it's published. We'd love to see the youth vaping work that you're doing. So George has got a question here. Appreciating there may not be consensus here, but generally how are e-cigarettes and NRT seen by Indigenous communities, as cessation tools or as a switch to a different nicotine product, i.e. is only nicotine abstinence seen as quitting?
Yeah, I guess there's like quitting and switching, I guess, is sort of the conversation that I'm hearing about. There's probably a few things. I guess the first one is, like, particularly among youth and young people, there's a lot of discontent about that from what I've heard. And I must say, I'm not speaking on behalf of Aboriginal, Torres Strait Islander people or anything like this. It's just the bits and pieces that I'm sort of picking up on. I guess I have the privilege of hearing from a whole heap of different people about this. So the first issue, I guess, is youth and young people and uptake, particularly among never smokers. So that's a real concern. And I guess thinking about Indigenous people, I speak about colonisation, and I guess I try to centre that around, well, not centre it, but I spoke about my experience with colonisation and my mum's experience and how that impacts our day-to-day lives. And I say that because it's not necessarily the first time a new substance has been brought in that might be seen as a silver bullet or might be a solution. So I think thinking about that perspective and thinking about health and wellbeing is a much broader issue than physical health and wellbeing, can actually change, I guess, your understanding of e-cigarettes and what we're talking about. When we're looking at a substance dependence and we're looking at that among a community, then I think that's particularly concerning. In terms of a cessation support, and I guess the policy at the moment is around trying to use e-cigarettes as a cessation support, then that's a different conversation. Obviously, we're talking about the same product, so it becomes a bit messy. And I think there's probably a bit more grey in it than we sort of discuss. And I think you sort of see very much a pro and anti e-cigarette discussion. And I think there's probably a bit more in common than people think. But so to summarise, youth and young people, never smokers, extremely problematic. Don't want to see it there. The flip side is obviously we want to support people to quit. We've seen significant declines. We know that there are a whole range of evidence-based measures supporting people to quit that aren't actually being used at the moment. We sort of spoke about those opportunities for cessation support that people aren't actioning. So I think if we can really utilise any of those referral pathways and other things, I think there's an opportunity there. And obviously, 66% of people are quitting cold turkey. And then the other challenge that keeps coming up is actually around dual use. So people then using both e-cigarettes and tobacco, but not quitting either, and sort of that having the effect or the synergistic health impacts of both e-cigarettes and smoking. So a complicated one that's probably, like you say, hasn't reached consensus, but I think there are a whole range of issues around it. And I've sort of seen or heard firsthand some of the discussion around trying to regulate or better regulate or otherwise e-cigarettes, particularly among schools and young folk.
They've got a question there in the chat from Wilson Raglan. So you reported a large number quitted unaided. Do we know what motivated them or how they coped with withdrawal, etc.?
Yeah, I think everyone sort of copes with cessation stuff differently. Motivations included health and financial costs were the two big ones, but then also the benefit of quitting for your family, children, young people, that sort of thing was one of the differences. I think there's quite a lot of evidence around, and this isn't to say, maybe I should say what I was going to say first. So there's a lot around there around using a strength-based approach. Like when I talk about colonisation, we've heard since the first boats came that Aboriginal and Torres Strait Islander people are inferior to everybody else. And so I think challenging that and having a strength-based approach, having discussions about every cigarette you don't smoke is doing you good. Quitting will help you see your youth and young people grow up. If I think about, 50% of people aged 45 and over passing away due to smoking, then if we're talking about NAIDOC and celebration of Indigenous cultures and passing on of languages, if we can prevent those deaths across the country, then there's an incredible opportunity for further passing on of cultures and other languages and other things. So there's an awesome opportunity there to unpack. Sort of gone off on a tangent there a little bit. But yeah, so there's plenty there that we can sort of do to continue this discussion.
Okay, great. And then, this question might be a little bit tricky because I didn't see any concepts of prohibition in any of the slides, but I'll give you a chance, Raglan.
No, it's a good question.
Yeah. Is there much support for prohibition of tobacco either in Indigenous communities or across the whole country?
Yeah, I'd be interested in this one because it does actually, and I think prohibition, maybe the language around prohibition's it comes across a bit harsh. And I guess if we focus more on the system that has, we've known tobacco kills for 70 years when used as directed or something like that. And we know that the harm is there. We know there's discussion. We've seen in Tasmania them trying to put through, smoke-free generation type legislation. We've seen that implemented by and led by Maori folk in New Zealand. And those conversations started in the mid-2000s. So been around the traps for a little while. And there definitely are communities that have talked about, how can we have a system that better supports people to be smoke-free? So one of the things we hear when I'm doing focus groups and things like that is, the government paid me in rations of tobacco. Now you're telling me you don't want me to quit. But then I go across the street to leave the medical service here, and I know there's 4 shops on the corner there that sell tobacco. So how am I meant to quit when I've got to walk past my dealer every day, several times a day? So that's an interesting one, and one that has come up in communities, particularly recently, and predominantly actually around e-cigarettes, is how do we regulate retail sales so that they're not selling to children and young people? Can we limit those sales to restrict the hours? Can they be selling, or should they be selling products at licensed venues where you can get liquor and tobacco and smokes and things like that? Or can communities actually be driving that conversation? If we think about sovereignty, self-determination, agency, can communities be saying, actually, we don't want to sell tobacco Monday to Friday here or over the weekend? Like maybe we can regulate those types of sales, especially given everything we know about tobacco. So yeah, those conversations are happening, probably more anecdotal than anything, but I'd be interested to see if when data comes up about that, because it's something that increasingly coming up as people grow frustrated of losing people to a preventable death or disease.
All right. Well, thanks for that, Raglan. I think we've now, if I've gone through all the Q&A chat, I think we've answered all the questions. So unless you had any final comments, Raglan, at all?
Just I guess to recap, like we know things are working. We've seen plenty of things happen over the last 70 years. I think the answers are in communities. I think people want to quit. It's just about how we get out and implement them. So to come back to your first question, Ryan, I think more resourcing, more funding, more supports, more human resources as well. I know probably everyone on this call are busy, so I appreciate you guys coming and joining with us for this conversation. But there is a demand out there, and there are communities out there, and Aboriginal and Torres Strait Islander people who smoke that don't want to smoke. And if we can get around communities and support people to quit who want to quit, then I think we'll leave the world in a better place. So I just wanted to say thanks very much and keep up the good work. And there's plenty more to be done.
Yeah. Well, on behalf of APSAD, Raglan, big thank you. Appreciate all your research endeavours with quite a large and heavily invested by the Department of Health, and rightfully so, program of research. And we wish you all the very best with continuing your efforts in communities. And that's it for today. So thanks so much, Raglan. And on behalf of APSAD, you're welcome anytime, any other member of your team as well. Thanks so much.
Thanks, mate. Appreciate it.
Goodbye.